Hey, good afternoon or good morning or good night, wherever you are in the world. Hello and welcome to this edition of the tipsRO webinar, which is today on radiation oncology education. So I'm delighted today to be joined by two of our authors from our recent special issue on global perspectives on radiation oncology education. And what's really nice about today's presentations is that one is focused specifically on professional education and one is focused specifically on patient education. So we think we have something for everybody today. Just some housekeeping rules before I introduce the authors to you. First of all, we definitely welcome your participation in the webinar today. So if you have questions for the authors, please feel free to put them in the chat during their presentations. Or if you want at the end, you can raise your hand, and if you're comfortable, you can take the microphone. So you have both options. The other point is that many of you will be looking for your CME or CPD code for your points, and we'll put that in the chat towards the end of the session, along with the download for the special issue where you can read all the papers. So without further ado, then I'm going to introduce you to our two authors today. So I'm delighted to be joined, first of all, by Dr. Alexandra De Leo, and Alex is currently a chief resident at the University of Florida. She completed her undergraduate education at Harvard and her medical school education at the University of Florida. And actually later on this year, she will commence as faculty at the University of Florida as an assistant professor, which is excellent news. Congratulations. And second of all, I'm joined by Matthew Maliozzi. And Matthew is a recent graduate of the Joint Medical Radiation Sciences Programme at the University of Toronto and the Michener Institute of Education at UHN. And he specialised in radiation therapy. And he currently works as a radiation therapist with BC Cancer in Abbotsford and specialises in brachytherapy, and also works with Electa as a data curator. So we're really looking forward to your presentations. So I'm going to ask Alex, if you don't mind sharing your screen, and I will then turn the floor over to you.
Of course. Thank you so much.
Thank you.
Okay, how is that?
That looks good.
Perfect. Thank you again for having me. My name is Alex De Leo, as was already said, and so today I'll be discussing our recent paper titled Challenges in the Transition to Independent Radiation Oncology Practice. And it really includes not only those challenges, but then also some of the targeted interventions that have been explored for improvement. So just to start off, of course, I don't really have any disclosures, but I do want to state that my perspective and my perception of this is biased by the fact that, one, I'm still currently a resident, so I haven't actually been able to transition yet that independent to independent practice, so I soon will. And also, I'm a resident in a training program in the United States. And so while I have tried to include some of the perspectives that I've identified from the literature of other countries, and I do think that a lot of the themes in this resonate beyond the United States, my perspective and bias is through the training programs in the United States and my own experience and other colleagues. So as we know, and as I believe is pretty common, not only here, but in other countries as well, radiation oncology training programs are typically designed by the apprenticeship model. And so residents or fellows are working typically one-on-one with an attending to learn their practice. But of course, this can lead to a lot of room for variation. And then without having a standard curriculum, at least here in the United States, or any sort of guidance for how residency rotations and programs should be designed in order to optimize, education programs, this can, of course, lead to a lot of differences between programs, and it can, affect how we're optimizing and managing our education of the trainees. And plus, over the years, and I think that this seems to coincide with some of the rules about supervision for trainees, some have said that there's waning autonomy through our training, and so then this can be diluting the experience and training that our residents and fellows have. Now, while the point of residency training or fellowship is to, of course, prepare our trainees for independent practice, I think that the transition, most of us will say, is something that can be scary, it can be difficult. And in what seems like an instant, we can go from being the ones that are under constant supervision to those that are expected to then supervise others and working on our own independently. And this change is often cited and identified as a challenge, as an obstacle, not only in radiation oncology, but in many other medical specialties, especially ones that are heavily procedural based. And on the right, you'll see the titles of a few articles, 2 from the United States and 1 out of Canada, which have identified specific challenges and obstacles, to having a more smooth transition to independent practice. And these have been identified through surveys of recent graduates, new attendings, and also through focus groups as well. So I'll discuss some of those challenges that they've identified and then highlight some of the ways that they've explored or others have explored in order to address what some have said are potential deficiencies in our training. So in order to do that, we compiled these challenges that have been reported throughout the literature and then grouped them into either technical skills or more non-technical skills. So first, I'll review some of those technical components that trainees have expressed having had inadequate exposure, and then talk about some of the interventions that have been proposed or requested. And then I'll move on to those more non-technical or intangible skills that are still expected of practicing radiation oncologists. So those technical skills that I'd like to focus on include treatment plan evaluation, which I think is honestly, at least in my experience and discussions with other people, one of the most frequently identified weak points potentially in training. Image verification and review of patient setup at the time of treatment, and then also the financial aspects of a radiation oncology practice. While all of these tasks are, of course, integral to the way that a radiation oncology practice functions and to our daily life, trainees consistently report having had insufficient exposure during training. And I'm sure that this is true for many reasons, but it seems like, the sense of having less experience in these areas has kind of worsened over the years. Again, as I mentioned before, probably coinciding maybe with some of the regulations in terms of the supervision and the level of attending involvement in tasks, which have really existed in order to try to improve patient safety and quality, but may come at a cost. So there is a trade-off, I think, between immediate risk and future risk, which there's a paper out of the surgical literature that has really had a very interesting figure that kind of identifies this, that shows that as you affect trainee autonomy during their training experience, by limiting that autonomy while they're in training, you might optimize or minimize the immediate risk to a patient if, let's say, they're not competent, they're still learning, and by maximizing the attending involvement. But on the other hand, if you're giving trainees more autonomy during their experience, that can impact the long-term safety and quality of our treatment of patients by giving the residents and fellows the opportunity to really learn during their training. And so I think in the middle, there is sort of this optimal balance between the two. And I think we probably just have to really find that. But in order to really address this, we have to identify what are the issues, what are the reasons why the trainees are not having the experiences that they need to during their training, what is limiting us, is it time constraints, are it these rules, and how can we really address this and improve this in our training programs. So as I mentioned before, it really seems like plan evaluation is a frequently cited deficiency in radiation oncology training, at least here in the United States. You can see this is a title from a survey that was published a couple of years ago in the Red Journal, which 60% of the respondents, the survey was targeting radiation oncology residents, felt like they had had inadequate training and exposure to treatment planning. And most residents are saying that they're not reviewing most of their plans with their attendings. So there are ways that, of course, we are learning about plan evaluation during our training. So besides the training that's provided by each individual program, which, as I said, can be variable, of course, and has already been identified in a survey like this, can be deficient. There are some readily available resources that are online. So for example, there's an article called CV-CHOP, and many people utilize this method, at least here in the United States. But again, it's not clear exactly how many. This is a simple standardized mechanism for how to approach treatment plan evaluation, but it's really just a starting point. It just kind of gives you a basic layout of what to do, and it doesn't really necessarily prepare you for specific experiences or certain trade-offs that you're going to have to decide between it when it comes to plan evaluation, because it doesn't really provide those specific examples. And IROC is an introductory course that's available for residency programs to use, and it does address some examples and some concepts when it comes to plan evaluation. But again, you know, it's not really that comprehensive, but that's expected. It's just an introductory course really intended to target brand new residents. And there are webinars that are available on our ASTRO and ARO websites, which are our organizations here in the United States. And they do have here, you know, disease site-specific cases that are led by the attending specialists in that field that really address certain cases, and they're in videos that are going through them. But, you know, that would require trainees to spend time outside to watch these videos. And it, again, may not address all of the specific situations that they're going to encounter. And then most of all, it's not really providing them with the hands-on experience that really is needed in order to master a skill like this. You know, in those surveys and in those focus groups, a number of people have identified what they are looking for and what they would want in their training to really have more experience and exposure to plan evaluation. As you can see in one of the quotes from the attending physician on the left-hand side, some have said they just wish that there was a bank of all of these cases and situations that they could go through and see what others have done and how to approach it. And the other suggestions have been for more low stress evaluations. And again, some of that hands-on experience and practice in really learning how to do plan evaluation. On the right, you can see a publication from a group out of Canada, actually, that published about their really exciting work in creating this program that provided that bank of cases. And what was really nice about this was that the cases had opportunities for improvement in their plans, meaning that it included cases that had some issues that it wanted the learner or the user of this program to be able to not only identify, but then to be able to think of ways that they would request, you know, adjustments and improvements out of these. And so you would see the plan in the beginning, try in a text box, identify what the issue is and what those improvements could be. And then it would show you kind of the correct answer. As far as I know, unfortunately, this has not been able to be spread beyond Canada or beyond this individual program. I think having to do with some issues with patient privacy when it comes to these programs, though I'm not totally sure. But I think that this is a really exciting example and a way to address an issue like this that we can all build on. Another thing, learning the ropes, you'll see on the left is a project that we have out of the ROCSIG GME group that's really early in development, but it's trying to not only address the fact that there isn't really a standard curriculum or set of didactics for how we teach plan evaluation, which is still really in the works. And I think that that is the foundation of how we need to teach our trainees, but it's also trying to address the issue of providing more case-based examples and hands-on practice. Now, besides plan evaluation, patient setup and image verification is another integral part of radiation therapy in our daily practice, but it seems like trainees are getting less and less exposure through this, even though image-guided radiation is prevalent and it's continuing to evolve. And so this group out of VCU created a simulation workshop where trainees in the United States were able to identify not only multiple issues that are involved with this, the types of setup imaging that are available, what are the important factors that they should consider, what are triggers for delaying treatment or even replanning. And personally, I hope that more simulation programs like this are developed and become available for trainees to use. And lastly, in terms of the technical aspects, the financial aspects of radiation oncology, usually remain in mystery and are not really as well taught as they need to be, since this is an expectation of an attending in practice. And unfortunately, I'm not aware of a specific curriculum or initiative that addresses this issue, though I do know that, of course, individual programs have their own ways through lectures and workshops to address these issues, and usually in partnership with their financial office. Now, besides the technical skills that are expected of radiation oncologists in independent practice, you know, there are also those qualities that are a little bit more intangible that are important for most, if not all, people in medicine. And these include leadership, interdisciplinary communication, mentorship, and teaching. And again, this is not exclusive to radiation oncology, but I think that leadership and interdisciplinary collaboration are especially important in our field, given our role with respect to other oncologists that we're working with on a daily basis. And then, you know, the unique team members within our own department, like therapists and dosimetrists and physicists and beyond. So again, as in other fields, you know, leadership has been identified as a quality that is important for our physicians, but it's something that really can be developed in training, and it's not just a personality trait or something that is, you know, not able to be built upon and taught. And I really like this quote out of this program, actually, that's done in collaboration through the groups in Europe, Canada, Australia, and New Zealand, that says, "Great leaders are born, not made, or are they?" You know, and so the thought that you can actually learn to be a leader and develop those skills. And another program that is under development here in the United States is one of those roles that we really need to learn and develop. Being a leader is in tumor boards and multidisciplinary conferences. And so they've really focused in on that setting and tried to make these mock tumor boards, or these artificial settings where you can practice those difficult discussions and, you know, defending why you're making a certain recommendation, for example. And finally, residents are expected to transition from being taught, being mentored, to then providing teaching and mentorship, you know, with little training in how to do so effectively. And this is especially important in academic centers. And, you know, there are a couple of ongoing initiatives that were presented at the ROCSIG meeting last year that are really intended to develop those skills within residents during their training, and providing them with helpful tools to teach them to teach and mentor the next generation. And so to conclude, you know, I believe that all of these individual factors are important to the transition to independent practice, but this overarching theme of providing residents with more autonomy, more graded responsibility throughout their training is really the most important, the key thing. And so I want to highlight these two experiences that are out of Mayo and Duke here in the United States. And at Mayo, they created this senior rotation where the chief resident is able to kind of mimic the experience of being an attending and function autonomously while still having access to, you know, the support and of their attending physicians. And then the VA rotation at Duke is available to trainees of all years. So it differs depending on what year in training that you're actually performing the rotation, but they're really intended to give you more opportunities to function on your own without as much involvement of the attending, but still having, again, that support to fall back on. So it probably is difficult, and I can say that from personal experience, to launch similar programs in other places, because there are some differences in some of the supervision rules at each of these places that I won't go into, but I think that the principle is the most important part. The key is finding ways to optimize, I wouldn't say maximize, but optimize training autonomy in order to really ease that transition to independent practice. So thank you so much.
Brilliant. Thank you so much, Alex. That was really, really interesting. And of course, your accompanying paper is, it's just kind of a snapshot of everything that you have in the paper. So I'd advise people to read the paper in detail. And some of the things that you mentioned there are quite interesting for us in Europe. So, for example, billing, you know, it's obviously totally, you know, different for us here than it is for you. So I find it interesting that that's down as a technical skill. But what I wanted to ask you, and just having a look at the chat, I don't think there's any questions there, but one thing I thought was quite interesting was your idea there at the end about the kind of the residents as faculty. So the kind of, I guess, kind of like peer tutoring or peer learning. And what I was wondering is now, as you're about to embark on a career teaching yourself, you know, do you really think, I suppose people can be excellent clinicians, of course, you know, and excellent radiation oncologists or therapists or whatever, medical physicists, whatever the field is within radiation oncology, but it doesn't necessarily mean that they're excellent teachers. And I just wanted to know your opinion, or what do you think about, you know, kind of a prerequisite of faculty to actually have teaching, you know, experience or to have teaching qualifications? Because that's something that we hear a lot about in Europe.
Yeah, I mean, personally, I think that that is key, especially if you are a faculty member that is involved in a training program and having the exposure and interaction with the trainees and really shaping their career, of course. And out of personal experience, again, you can have a lot of differences in your rotations depending on how involved the attendings are and how interested they are in your education. For our requirements for attending and being at the University of Florida, and I'm sure at any academic center, they do have stipulations for faculty development and, you know, participating in educational initiatives. And I don't know necessarily like how effective that each one can be. And a lot of it, I'm sure, is how much you put into it. And I do think it would be really useful to have some sort of baseline expectation, some sort of baseline training for how to effectively teach training.
Yeah, I think so. Yeah, I think it's, you know, everything has changed so much in teaching and learning in the past, even since COVID, but in the last decade, that it's, you know, what I used to do a decade ago, I don't do now, you know, so it's quite interesting. I see there are some questions in the chat, so I'll go to this one from Mike. Alex, is high proficiency of technical skills actually needed in clinical practice, as some arguably should be driven more autonomously by other experts, therapists, billing administrators, etc.? Yeah, I was wondering, thinking that myself, Mike, particularly about the verification role, you know, because certainly I can't say in Europe in general, but certainly in Ireland, verification would be very much a therapist's role.
I think that's personally an excellent point. This might be something that is distinctive about the United States specifically or my department, but I feel like the responsibility seems to come to the physician. And besides that, just the experience of going to the machine or reviewing the images when you don't have experience can be something that is a little bit daunting. And even if it is a quick transition to learning how to do it in practice or relying on your team members, which I totally agree should be, you know, the ones that are more responsible for it, and they're the ones that are especially trained in it. I think that being said, it's still something that isn't taught as much as it should be, even if the amount that it should be taught in training is just a little bit.
Yeah, I've certainly heard colleagues in Europe talk about that before, and actually I was approached by some of them to have an ESTRO workshop specifically for radiation oncologists about on treatment verification. So I don't think it's a unique issue to the US. And there's one other question that's a little bit philosophical, so I'm not quite sure if you're going to be able to answer this. It says, in leadership, what is ethical practice? That could be, we could debate that all day, but maybe you could, I mean, how, I suppose, maybe you could talk a little bit about how are ethics taught? Are they taught specifically in the radiation oncology program, or is that something that's kind of covered at medical school?
That is a great question. In my personal radiation oncology residency program, we don't have any specific targeted training about ethics besides, you know, the interactions that you might have on a daily basis and whatever comes up in clinical practice. It is something that is focused on or was focused on during my medical school experience, but I think that there are specific situations in radiation oncology and cancer care in general that can come up, and it would be an interesting thing to add to our curriculum, which is still in development, but I don't know.
Yeah, for sure. I'm thinking, you know, things like, you know, palliative end-of-life care.
Exactly.
You know, maybe patients who are pregnant, you know, I mean, it's quite a thought-provoking question, Prakash. So thank you for that. Great. Okay, well, thank you so much, Alex. And I know joining us again for the overall discussion at the end. But now I might turn to Matthew next. So Matthew is going to present to us his manuscript, which is entitled Virtual Integration of Patient Education in Radiotherapy, which is the VIPER, very catchy title, the VIPER study. So Matthew, if we could ask you to share your screen when you're ready. Great, thank you. Perfect. Yeah, that's perfect. Okay, so over to you, Matthew. Thank you very much.
Awesome, thank you. Before I moved across the country to be a radiation therapist in BC, I studied at the Michener Institute and University of Toronto. And in my third year, I decided I wanted to do a research project. Luckily, I was paired with my research supervisor, Michael Velick, and together we composed this project on the screen. So to start today, I just want to give a brief background on kind of where we came up with this idea. As everybody probably already knows, the COVID-19 caused a lot of in-person restrictions. And on the right side, you can see the graph depicting that a little bit, and that's from Berlin et al. Approximately mid-March, when the pandemic was declared, the use of virtual medical care increased from less than 1% to approximately 68%. And as you can see, the main modality for virtual care was actually telephone education or telephone care at 81%, with a small minority being video conferencing as well. However, we felt that telecare, as it was a really good short-term solution for the in-person barriers that the COVID-19 pandemic was causing, we felt that it lacked a lot of visual aids and engagement required for some adult learning styles, and therefore wanted to introduce our own form of virtual education into the standard practice. But before doing so, we had to first determine the feasibility of using virtual education while also measuring the acceptability from both staff and patients. So this project was a single center prospective quality improvement pilot, and the current practice for radiation therapy was teleeducation. So approximately one day before their initial CT simulation appointment, our patients were undergoing a telephone call with a radiation therapist, and they were discussing what to expect for treatments, what to expect in terms of the CT simulation, side effects, everything pertaining to their radiation therapy journey. And we essentially wanted to get all this content and convert it into virtual education, which was defined in our project as being video conferencing delivered remotely via Microsoft Teams, PowerPoint guided, and in a one-to-one setting. However, we also invited support members like family members to attend if they wanted to. And on the right, you can see a brief snapshot of what it might have been like to be a patient in one of these virtual education sessions. And as you can see, we have a picture of just the linear accelerator to give them an idea of what the room will look like when they arrive for their first day of treatment. We also have a little bit of text that they can follow through, and we also have some visuals. So we circled, for example, the microphone in the top left of the picture just to highlight some of the things that we were hoping to focus on to better guide the patients through their education. So once we had all of our PowerPoints in place and everything organized, we essentially needed to train our radiation therapists to host these sessions. And they got individual training on the video conferencing platform, Microsoft Teams. So they were taught how to mute their microphone, unmute, show their cameras, and progress through the slides. Also provide some minor technical support to patients that might need it. We also covered the workflows and how we would like the PowerPoint presentations to be presented, as well as the institutional best practice guidelines for virtual care. Once the radiation therapists were all trained, the next step was actually recruiting patients for the study. And before the initial phone call for consent to participate in this study, we first had to make sure that they were booked for pre-treatment radiotherapy education, as well as previously agreeing to the use of email for routine clinical care. If a patient checked both of those boxes, then we got the essential green light to call them to participate in this study. And during the phone call for consent, we obviously had to obtain consent and also inquire about the patient's technology access, as we needed to ensure that they had a laptop or tablet along with a microphone and camera to access the session. We also tried to avoid the use of cellular devices like an iPhone or Samsung, as we felt the visuals would have been just slightly too small to get the full effect of the virtual care. We did have one piece of exclusion criteria, which was just if they've received a previous course of radiotherapy. And that was just because that education might not be as complete as someone who's going through their first round of radiation therapy. Basically, any other patients who either didn't meet their criteria, were excluded, or maybe weren't reached by phone call, and we'll talk a little bit about that on the next slide, actually, were scheduled for teleeducation as per the standard practice. So as I mentioned, this is just a flow chart of our clinical operations and how we went about recruiting and gathering all of our data for our study. Initially, we had 297 patients that we screened and found that 220 were eligible. And you can see some of the reasons why they weren't eligible, as we discussed on the last slide. Of the 220, we approached 139. And again, you can see some of the reasons, with patients just not being reachable being the main reason why we couldn't approach some of the patients. When we tried to give them a call, they just either didn't pick up. We attempted our best to call patients at least 48 hours before their scheduled teleeducation appointment, as they might have to prepare a little bit for the virtual education with the technology required. Additionally, of the 139 patients, 76% of the patients opted in for the virtual education, which was great to see that there was a high interest in actually progressing with the virtual education. And then of the 106, we had 85% completing the virtual education, with our average session length being 36 minutes. Other than that, our patient characteristics, majority of them were GU patients, prostate specific, and there was no specific reason we picked this site to start. It was more so logistical and approved by leadership. Moving on to a little bit more of the results. We asked a lot of questions, I would say approximately 8 to 9 for the patients and therapists. However, I tried to condense it to just 4 questions that we kind of similarly asked both the patients and therapists. First, with the patients, we had 100% of the patients responding that these virtual sessions helped improve their understanding of their radiotherapy treatments, and also 100% recommending that it continues for other patients, which was really great to see. We also had close to 100% that were satisfied overall, with just 1 patient that was neutral. And as you can see, there are varying results for the outstanding questions, which might not look very appealing on the chart, but actually was something that we were looking for when we first had this idea. And I'll talk a little bit about it on the next slide as well, but essentially we were hoping that patients would get more engaged in their learning. And if they had more questions during or after the session, it could indicate that they were a bit more engaged in their educational sessions by asking those questions. And that trend is also seen a little bit just from the therapist specific surveys, as majority either answered strongly agree or agree, and none actually answered disagree or strongly disagree to the outstanding question that we had to ask on the survey. Additionally, we asked our therapists to be very critical of this project. This was a pilot project, so we wanted as much feedback as we could get. We got ad hoc feedback throughout the project and used a plan, do, study, act framework to implement changes as we progressed. And some of the feedback was really great from the therapist, and we made a lot of changes as we went. And overall, we found that we had really good acceptability from our therapists once we were able to get the project going and stable, especially with the technological training and requirements for the sessions. I've also included 2 quotes here, one from a patient and one from a therapist that underwent these virtual education sessions. First, from a patient: "Because I am a visual learner, I appreciated the PowerPoint presentations. It made it easier to understand." This was a really great quote to get, as we previously mentioned already. A lot of patients have different learning styles, and we wanted to make sure we were accommodating those visual learners. It's probably the reason why this is a webinar instead of a teleconference, is because some people do value those visual guidance and PowerPoint guidance during educational PowerPoint presentations, and that was just really great feedback to see from a patient that actually underwent one of our virtual sessions. Additionally, the ability to show pictures makes it easier to explain and describe procedures, i.e. mask making, daily treatments, etc. More personalized experience for patients. That was a really great quote as well from a therapist. It can be difficult sometimes to describe our radiation therapy procedures over the phone, especially when it comes to things like the masks, where patients are probably a little bit more anxious about them, and trying to describe to them how it starts very hard and then we heat them up, it becomes malleable, easy to form around the face. So it's really easy to describe those things when you do have accompanying pictures. Additionally, even the tattoos are some things that patients are a little bit more anxious about. So just showing them a picture of what a tattoo looks like and showing them how small they are might help settle some nerves before their initial CT appointment. So overall, we found that our patients, from a patient's perspective anyways, there was a high completion rate with minimal tech issues, which was really good to see, because initially we thought that the technology required to access the sessions could be a barrier to this form of education. But we found that even if patients did have some issues or concerns about the technological requirements to operate the sessions, that they had a family member or support member that was able to further help them and guide them through the online sessions. As we just saw on the previous slide, we had an enhanced understanding and preparedness for radiotherapy sessions with high acceptability. And when asked, they actually preferred this virtual education over in-person and teleeducation. Additionally, from the radiation therapist perspective, as we just saw, we had overall good acceptability from them. And when asked, it was suggested that it was comparable to the in-person education, which was another one of our minor objectives in the study, to see how closely comparable we can get it to in-person education. So that was really good feedback to get as well. Some of our future work, we hope to expand this to all patients receiving radiation therapy, and more specifically explore the patient-specific education needs assessments and offer different options to patients. Because if we briefly switch back to this slide, you can see that some patients actually declined virtual education because they prefer teleeducation. And we just wanted to make sure that we're accommodating all the patient needs required for sessions. Lastly, I just obviously wanted to make some acknowledgements to my research supervisor, Michael Velick, who really helped push this project along, to the radiation therapists who didn't really know what to expect going in, but did an awesome job throughout the sessions, and then to the clinical sites and my education sites as well. So thank you so much for this opportunity to present. And yeah, if there's any questions.
Excellent. Thank you so much, Matthew. That's such an interesting study. I think it brings up so many, it's so, I suppose, relevant to everybody, you know, no matter where they are in the world. But I'm thinking of people who have large distances and things to cover with their patient population. But before I ask a question, I see there's one in the chat for you already, saying from Prakash, how much total time, how much basically on average did each patient get for the virtual education? Because I know in the paper at one point, I think some of the therapists had said that they're running out of time for the allocated, you know, they had an allocation of time for the patient and they were running out of it. And then the other question from Prakash is, were there any limitations of this virtual education? So if you don't mind addressing those two, please.
Yeah, absolutely. We essentially allotted the same time slot for each patient, and to keep it consistent with the teleeducation that was the current standard at the time, we decided just to keep it the same length. I believe it was 30 to 40 minutes was kind of their window. Okay. The average length of our sessions ran approximately 36 minutes, but on the PowerPoint slides I did show one session did run 80 minutes. So that just reflects the amount of patient questions that were asked during the virtual sessions. And as I mentioned, that was actually kind of a good thing to see, because it meant our patients were really engaged in their education sessions. And maybe we just needed to better guide them through some of the slides to make sure that they had room for more questions at the end. Some of the limitations like I mentioned, technology was obviously an initial thought for limitations. And we felt that patients did have support members that were able to provide technical support to them during the sessions, if needed. And we didn't find it as much of a barrier as initially thought, which was really good, actually.
Yeah, and I noticed as well that in your in the paper you had like a really wide range of patient age, you know. So I see it's like 27 to 93. So, and then the median age was 65. And it's interesting because we here run a massive open online course, which is fully online for patients. And like that, when we started it, everyone told us, oh, you know, you can't do that because older patients won't use technology. And I mean, it was completely disproven. And I think you've done the same as well, that kind of stereotyping on technology and age is not, you know, doesn't hold true these days. What I was really interested in was looking at the different tumor sites that you had. And I was really kind of very pleasantly surprised to see that you had, like, I think 29% of head and neck cancers, which, you know, I found really interesting because I was just wondering, you know, are they kind of a range of head and neck cancers, or were they very specifically, like, say, HPV positive oropharyngeal patients? Or, you know, because I know, you know, we've tried to engage, you know, more traditional head and neck cancer patients in education programs here before, and we've had very kind of patchy success. So I was just wondering how that was so successful for you, because I think that was really excellent.
Yeah, no, great question. I think we, at Princess Margaret, they do more of a teams approach, and they had more of the head and neck team site. Yeah. And our slides were somewhat broken down for individual sites, but they were more big picture sites. So just oropharynx, nasopharynx, stuff like that. And those were kind of the umbrellas that we just push patients under. And then during the sessions, if there was anything specific to a specific patient, we gave the therapists freedom to feel free to discuss it or answer those questions as well.
Yeah, no, I thought that really stood out for me in your figures. And the other thing that I was wanted to ask you about was, I thought that you would have had a lot more kind of family members or carers joining, but I see in the paper it was like 7% of sessions additional participants joined from or maybe was it just they joined from a separate device, or was it just that was the total number of carers or family members that were there?
That was from a separate device. So we did give patients permission to share the link with their family members if they wanted to join from a different device. Before each session, we just asked the patient to consent to their surroundings, because we could control what's on this side of the screen, but not on that side of the screen. So as long as they were comfortable with everybody in the room and everyone on the screen, then that was okay to proceed with the session. And
did a lot of them have someone with them, or?
Yeah, a lot of them did. Yeah, I think even in person, as I'm doing some education sessions here in BC, you find that a lot of people come with a support member or family member. And that similar aspect was also there for the virtual care.
I'm just thinking how excellent it is for, you know, if you think you have, I don't know, say your parent is for treatment and you're in a different country, you know, how nice it is that they have the opportunity to join and actually hear what's going on, you know, because sometimes in your mind when you're far away, things, you know, seem much worse than they are when you can actually hear the information for yourself. Okay, let me just check that I'm not missing any questions for you. I don't think so. Let me just click those off. So then for the last few minutes, I just kind of wanted to speak about maybe with both of you. And of course, feel free to, you know, because of course we're all radiation oncology professionals, so you don't just have to answer on your own topic, but feel free to come in on each other's questions as well. And one thing that I wanted to ask you both about was the role of online education for both patients and for radiation oncology professionals. And I think one of the things that, Alex, that you had talked about was, and I was taking notes as you were speaking about it, I had some ideas going through my mind about the treatment plan evaluation aspect. And I think in your survey, it was like 60% of people who were surveyed, or residents who were surveyed, were unhappy with the level of exposure that they had to treatment plan evaluation. And I was just wondering, you know, do you feel that, maybe online education, not that people should be moving outside of their programs to look for things, to bridge the gaps, even though it's apparent that they do in every country. But do you think that there's a role for online education or hybrid education somewhere within the radiation oncology training program, specifically for aspects such as the image verification that you mentioned earlier?
Yes, and I couldn't agree with you more. I think one issue is addressing this within our training programs, because of course that is what is expected, is education through the program itself. But as you mentioned, people are already bridging the gap through online resources. And one example that's extremely popular for contouring guidance is eContour. And I know that they are in development with somebody that is in the ROCSIG GME group, actually, in creating what was referenced, one of those banks that has example plans that you can evaluate. I don't think it's necessarily in conjunction with a specific contouring plan, but regardless, trying to create those banks that have examples of plans that could use improvement, and then what suggestions you can make in order to address those improvements. So I think that there is a lot of room for online resources. Personally, my bias is that we should be addressing this within our residency programs first, and then complementing it with additional online resources. But I think that there is a huge role for that too.
Yeah, it's interesting. I'm just thinking, well, obviously in Europe within ESTRO, we have the Falcon contouring, which I'm sure it sounds pretty similar to the e-contour that you've mentioned there, but that's specifically just for delineation. And I'm thinking, about your point about treatment plan evaluation in particular, and certainly I do some work with the International Atomic Energy Agency, and there's I suppose some online tutoring specifically for radiation oncologists in Africa called AfroNet, where plans are looked at as like kind of a virtual tumor board. They're presented, and there are some experts who are looking at them, and this kind of peer over and back feedback. And I find it kind of quite interesting that sounds like something to me that actually would be really worthwhile for everybody. It doesn't, not just specifically one region of the world, if this is an issue in lots of regions. So yeah, I just had that in my mind when you were talking about that. And Matthew, then for online education for patients, I mean, obviously what you did was like a virtual, it was online but live, but I'm wondering what you think about maybe some kind of asynchronous, offline patient education. I suppose I'm thinking quite specifically about patients maybe with low health literacy, low literacy, or even, we obviously have mass migration in the world at the moment, and people who speak different languages. What's your opinion on that, or what do you think?
Yeah, I think self-directed education is definitely an avenue that we can focus on moving forward. I think it's important to really ask the patients and see what assessments needs they need for their education before offering them a choice between virtual care, telecare, or even self-directed care. Because as you mentioned, there are some patients that did have language barriers, and luckily we did have some family members come and translate some of the minor things, even though that the patients can pick up on some of the bigger English.
Yeah.
And self-directed learning is already kind of a thing at Princess Margaret, I think, but it maybe isn't as accessed or advertised as much, maybe as it should be, for offering education to patients, regardless of the center, actually.
Yeah, and one thing that we have found here, I suppose the only negative that we have found here using something like our massive open online course, is that we tend to, reach actually quite highly educated patients, who are very highly motivated. And I suppose I've never really been able to work out what's the best way to meet the needs, kind of up with online resources for those from lower socioeconomic groups. So in your study, did you have any kind of, I didn't see it in the results, but was there any kind of disparity between, people who had certain levels of education to others, or did you ask that question?
We unfortunately didn't ask that question. So there's really no way of us knowing for sure. I think from what I saw and from the patients that we called, it was probably a mixture of them.
Yeah.
From different levels of education for sure.
Yeah, but it's good that it was different levels because, you know, I know our program has been taken by about 10,000 people, and I think something like 70% have a minimum of, you know, an undergraduate degree. So, you know, so we're always kind of open to any kind of suggestions about how we reach, I suppose, the you know, the other, I suppose, the other patients that we don't necessarily, you know, that we see quite a lot of, but we find it very difficult to reach them, I think. So so Alex, I might just for the last couple of minutes just come back to you. I was just wondering about, you know, we've talked a lot about what else needs to be in the residency training program, and of course, you know, in terms of bulking up the verification and the treatment plan evaluation. But of course, you know, there's only so many hours in any program, in any training program. And what I was wondering is, you know, are there you know, are there certain things that you think could be superseded or could be, you know, overtaken in the residency program, or that are, you know, need to be maybe moved out a little bit? And the reason I'm asking you that is that certainly in radiation therapy, we're thinking a lot always in our curricula about you know, the role of artificial intelligence, where it's going to lead. Do we all need to be sitting learning? You know, for example, we have a 10-credit module here in treatment planning. Do we need to be teaching all of these treatment planning skills, or should we be focusing on what's the best plan, you know, selection? So I don't know what you think about that.
That is an excellent point, and something that I've encountered also when discussing for our oral boards what we're expected to know and how it may not exactly reflect what you need to know in practice, but those are the things that you're tested on. And is it a little bit of a, you know, reflection of how we used to do things, and should this be something that's removed from the education? And I came across this term, curriculum hypertrophy, where
that's a good one.
We keep adding things without really taking careful consideration of what we may not need to necessarily learn and impart on our trainees. And I think that there is a lot of value in some of the basics when it comes to treatment plan evaluation and trying to visualize and understand exactly how a plan works and how to address it. But at the same time, I couldn't agree more. I think that we should be taking a closer look at what things that are not as important for trainees to know, especially since we're moving more towards, you know, contour-based plan evaluation, as opposed to specifically knowing, you know, the borders of a treatment field as much as we used to need to know. So I think that we do need to do that as we're thinking about educational initiatives to add into our programs when there are so many hours in a day.
Yeah, that's fun. When we have a curriculum review here, that's always my bottom line. There's only so many hours in the curriculum, so you know the students get a little bit upset if you keep adding the whole time. And then Matthew, just to finish, one burning question that I wanted to ask you, if that was okay, was about the feedback that you got from the therapists specifically, because I was just looking at your results bar there, and I think of the 12 therapists, I made it out that maybe about 30%, so maybe 4 of them said that, I don't think they said they weren't satisfied, but there were obviously some suggestions that they had for the improvement of the pilot. I was wondering if you could share with us what those were.
In terms of the improvements?
Yeah.
I think it was just better integration of the technology. It was really the initial barrier. We kind of collected that therapist data at 2 points in the study. 1 point at about a month in, and then I think the next time at about 3 months in. So some of that therapist data does reflect that earlier stage in the pilot, where we were making our way through that Plan, Do, Study, Act framework, and addressing some of those technological barriers that we were facing. And then once we kind of settled some of those, we found that some of the results from our therapists were a little bit more easygoing. I think also just navigating a PowerPoint presentation online is a little bit more of an effort than making a phone call as well. So it can be a little daunting at first to have to make that switch. But I think once they settled in, they realized how beneficial it can be for the patients as well.
Yeah, and as you say, because it was a quality improvement project, you know, you're expecting that kind of feedback in that cycle so that you can implement it the next cycle. So great. Okay, well, thank you both very much. That's been really, really interesting and, well, for me, fascinating last 55 minutes with you both. Just for the participants, I just want to point out to you that in the chat now, you should be able to see the code for your CE certificate. And also Bobby has kindly put in the link for our special issue where you can, if you haven't already read Matthew and Alex's papers, you can go there, and obviously they're open access, so you can go in and download them for free. And we also have lots of other really fascinating papers from all around the world. We have quite a number from Australia and our Australian colleagues. Because of the time difference, we didn't expect them to get out of bed in the middle of the night to join us today, but there's some really, really fascinating topics there for you to take a look at. So with that, I think there's nothing else for me to do except thank you very much, Matthew. Thank you, Alex. And thank you to Bobby in the background that the participants don't see, but who has been keeping us on the straight and narrow here. And I'd also like to thank Ashley Murphy from Elsevier as well for organising today's webinar with me. So have a great night, day, afternoon, evening, and we look forward to you joining us again for the next tipsRO webinar. Thank you.